You can execute a technically flawless breast reconstruction. You nail the vascular anastomosis, you get that perfect symmetry in the mound volume.
Right.
But I mean, if you miss the mark on the nipple-areolar complex, the eye just goes straight to the
Oh,
eye.
absolutely. It ruins the whole aesthetic.
Yeah, exactly. So today we're jumping into a deep dive on how to master that final visual keystone. We're synthesizing clinical guidelines, flap design protocols, all that real-world strategy for you, the plastic surgery resident or attending.
And, the clinical reality is that this is arguably the most nuanced stage of the entire reconstructive process
For sure.
because we are rarely working with pristine native skin here. We're manipulating second-generation tissue, right? Mastectomy flaps or transferred autologous flaps.
Right, so you're constantly battling like compromised vascularity, unpredictable dermal thickness.
Scared bits, yeah, all of it.
So we are skipping the basic definitions today. This is strictly surgeon to surgeon. We're jumping straight into the real-world clinical pitfalls, practical hacks, and the actual mechanics of achieving lasting projection.
Sounds good. And honestly, before anyone even thinks about picking up a scalpel, we have to address the single easiest way to completely ruin the case.
Bad marking.
Bad marking.
Yeah. Because the immediate instinct in the clinic, especially for a junior resident, is to just grab a tape measure.
Oh, yeah. Every time.
Right. You look at the contralateral side, measure the distance from the sternal notch, measure from the midline, and then you just try to triangulate those exact distances over to the reconstructed mound.
Common pitfall right there. Relying on pure mathematics or placement is it's fundamentally flawed.
Because the reconstructed mound is never a perfect geometric mirror of the native breast.
Exactly. I mean, the underlying volume distribution is completely different. The footprint on the chest wall varies.
Right.
And the way the skin envelope drapes over an implant or a flap, it just behaves differently than native glandular tissue.
Yeah, especially if there's an underlying ptosis on the native side.
Oh, definitely. If you just rely on the math with the ptosis, that mathematically plotted point is going to fall right off the true apex of the reconstruction.
You end up with a nipple that points down.
Or sits totally off center, yeah. The vectors simply do not match. You have to find the natural visual center of gravity for that specific reconstructed round entirely independently.
So what's the hack there, the cover-uncover aesthetic method?
Yes, that is the most effective clinical parole for this. You literally physically cover the contralateral native breast. Completely remove it from your visual field.
Just ignore it completely.
Yep. Study the reconstructed mound entirely on its own. And you place your mark where the nipple location intuitively appears appropriate for that specific topographic shape.
And then, only then, do you uncover the contralateral breast to compare.
Right. You let the reconstructed mound dictate its own ideal focal point first. Then you tweak for symmetry. It forces you to respect the anatomical reality of the tissue you actually have right in front of you.
I love that. And there's actually a really effective hack for integrating the patient into this phase, too.
Oh, hey, the bandage trick.
Yeah, the bandage trick. You place a simple, round, adhesive bandage on your chosen spot, step back, hand the patient a mirror, and just let her physically adjust that bandage to where she feels it belongs.
It's brilliant. Giving the patient agency in that final aesthetic placement, it really changes the entire dynamic of the case.
It does.
Because honestly, their aesthetic intuition for their own body is often incredibly accurate.
But, okay, let me push back a bit here. In real life, patient preference frequently collides with anatomical constraints.
Sure, that happens.
What happens when she moves that adhesive bandage like way medial, but, the tissue in that specific medial quadrant is just far too thin to support a local flap?
Well, that is the moment you have to step in and synthesize the aesthetic desire with the physiological reality. You just have to clearly explain the constraints of the underlying tissue.
Right, manage expectation.
Exactly. Now, in bilateral reconstructions, you naturally have more latitude. You're building both sides from scratch, so you can manipulate both mounds to match a specific medial or lateral preference.
But the rule remains the same across the board, right? Assess each breast completely separately before you start making compromises for symmetry.
Always. Always. So once the mark is locked in and the bandage is in the right spot, the challenge shifts to building actual 3D projection.
Right, the fun part. So if you have thick, well-vascularized autologous tissue, like a robust DEP or tram flap, local flaps are your absolute workhorse.
Absolutely. If that subcutaneous cushion is there, you build from within.
We're looking at designs like the skate flap, the CV or cervical visor flap, fishtail, penny flap.
Yeah, the specific geometry varies, but the core mechanics are identical. You're drawing your design within the confines of a 38, 42, or 45 millimeter cookie cutter template.
And then you raise the lateral skin flaps.
Right, but here's the key point. The success or failure of the entire operation hinges on the central dermal fat pedicle.
The tent pole.
The temple, exactly. You're incising down into that subcutaneous adipose layer, elevating that pedicle and standing it straight up 90 degrees to the plane of the breast mound.
Because the lateral skin flaps are simply the canvas of the tent wrapping around it. The structural integrity relies entirely on that fat.
And if you get sloppy with your dissection, like if you rely too heavily on the bouvier and cause thermal spread,
Oh yeah, you just fry the tissue.
or even if you roughly handle the adipose tissue with your forceps, you damage the delicate microvasculature.
Those perforators in the fat are so fragile. If you compromise that blood supply, the tent pole just undergoes fat necrosis.
It loses its structural rigidity and the entire reconstruction collapses completely flat within weeks.
But, even with flawless surgical technique and perfect tissue handling, these local flaps will inevitably atrophy.
Oh, without fail. They will lose volume and contract as the tissue heals and the edema resolves. Anticipating that contraction is a crucial clinical reality.
So you have to overcorrect.
Significantly, in unilateral cases, you must overcorrect. Make that initial flap 50 to 75% larger than the contralateral native nipple.
Which is going to look massive on the operating table.
Huge!
I mean, the patient will look at it in the recovery room and think it is entirely too big.
Yeah, you really had to prepare them for that visually beforehand. But the downstream logistics make this the only logical approach.
Because it's easier to reduce than to build up.
Exactly. If 6 months down the line, the final settled result actually is substantially larger than desired, doing a minor reduction under local anesthetic in the clinic is a very quick, simple procedure.
But trying to bulk up a contracted, volume-depleted nub is brutally difficult.
Almost impossible to get right. Always err on the side of excess projection.
Okay, so you've built this massive flap. Protecting that newly built projection immediately post-op is another challenge, right? The structural fortress has to withstand the compressive force of a surgical bra.
Right. And there's a highly practical dressing hack for this, using standard OR supplies.
Oh, the syringe hack.
Yeah. Take a standard 20 ml aerolay syringe and cut off the base. You basically use that plastic cylinder as a protective dome.
Right.
Cushion the surrounding skin with an iPad that has a hole cut in the center. Drop the syringe base over the new nipple flap. Pack a small amount of Zeroform inside the barrel for gentle support.
And seal the whole apparatus to the chest wall with Tegaderm.
Exactly. Or an arterial line protector functions exactly the same way. Just inject it full of antibiotic ointment and place it right over the reconstruction.
Provides rigid protection against shear forces while that dermal fat pedicle establishes its new vascular equilibrium.
Perfect for it. Now, local flaps are the gold standard when you have the autologous tissue. But attempting to raise a skate flap on thin irradiated skin is an absolute contraindication.
Yeah, if you're dealing with a prosthetic reconstruction, an implant sitting directly under a paper-thin mastectin skin flap, the subcutaneous fat layer simply does not exist.
You have no tent pole to raise.
Attempting a local flap in that environment guarantees full-thickness skin necrosis. You're just rearranging ischemic tissue at that point.
Right. So when you cannot build projection from within, you have to bring in outside structural support. You have to pivot to grafts.
Okay, let's talk grafts. If the patient has a very prominent contralateral native nipple, composite grafts are an excellent option for achieving perfect symmetry.
Because you just borrow from the healthy side to build the reconstructed side.
Right. If the native nipple has excessive projection, a simple transection is highly effective. You just amputate the distal 30 to 50% of the donor nipple and graft it directly onto the reconstructed mound as a free composite graft.
And if the native nipple is wide but maybe lacks the projection for a full transection, you alter the harvest geometry.
Take a central vertical wedge or a horizontal pie-shaped wedge.
Exactly. And then close the donor site primarily. But man, this approach carries a massive informed consent requirement.
Oh, huge. You are operating on a healthy, previously untouched breast.
The patient must explicitly understand the potential loss of sensation, as well as the permanent loss of erectile and ductile function in that donor nipple.
Some patients readily accept that functional trade-off for the guarantee of highly matched symmetry.
And others will absolutely refuse any intervention on the native side.
Which is fair. So if the contralateral nipple is off limits or anatomically insufficient to serve as a donor site, The focus shifts to the ultimate tool for lasting projection in thin tissue implant cases.
Homograft costal cartilage.
Yes, donated rib cartilage. It provides rigid, long-term projection without requiring a secondary surgical donor site on the patient.
And unlike dermal fat pedicles, cartilage actually maintains its structural integrity against the compressive forces of the skin envelope. It fights back.
But the surgical technique for placing this cartilage requires absolute precision. You're making your incision and dissecting down through the thin subcutaneous tissue to create a pocket.
Right down to the pectoralis major muscle, or directly to the implant capsule.
But here is the critical surgical pearl for this phase. Never perforate that capsule.
Never. The scar tissue forming that capsule is surprisingly vascular. It provides the crucial blood supply that will keep the overlying skin alive once you stretch it tightly over the cartilage strut.
If you breach the capsule, you destroy your vascular bed.
And you risk exposing the underlying implant to potential contamination.
Exactly. So once the pocket is safely established, the graft shaping dictates the long-term success of the procedure.
You carve the cartilage graft with a number 10 scalpel, and the design must be a subtle cone shape, not a straight cylinder.
Right. The base has to be wider than the tip, so it sits completely flush against the chest wall, distributing the pressure evenly.
And the anterior surface, the tip pointing outward, must be perfectly smooth. Taking a number 5 rhinoplasty rasp to soften that front edge is non-negotiable.
Because leaving any sharp cartilage edges sets the stage for the most common and devastating pitfall in this technique.
Extrusion.
Extrusion. The mechanism of extrusion is just pure pressure necrosis.
Yep. A sharp cartilage edge acts exactly like a tent stake, pushing aggressively against extremely thin, often irradiated skin from the inside out.
It creates a focal point of intense pressure that just strangulates the fragile dermal blood supply right at the apex of the mound.
You see the localized ischemia first. The tissue blanches, the dermal plexus dies, and the avascular white cartilage literally punches directly through the necrotic skin defect.
It's a nightmare, and you induce the exact same ischemic disaster if you place your quilting sutures too tightly around the base of the graft.
Right, strangling the base chokes off the dermal plexus before the blood can even reach the apex. Both technical errors lead to the exact same clinical failure.
Okay, so we have to address the material selection itself, though, because using homograft cartilage means placing donated organ tissue into the chest.
Right.
Considering the theoretical infection risks and the psychological hurdle some patients face with cadaveric tissue, advanced synthetic options definitely warrant discussion.
Like acellular dermal matrices, or ACMs.
Mm-hmm.
They provide robust structural support, and they're an excellent alternative.
Right.
They utilize processed dermis to create the necessary rigidity. The standard technique involves taking a 4x2 centimeter sheet of ACM and rolling it tightly into a cylinder along its long axis, securing it with absorbable sutures.
So that tightly rolled cylinder acts precisely like the carved cartilage strut.
Exactly. Now, if the mastectomy skin flaps are extremely tight, a simple cylinder might collapse under the constant compressive tension.
So what do you do?
To combat that, you take a longer rolled graft, bisect it, and suture the ends together to create a donut shape.
Oh, interesting. So that structural ring distributes the compressive forces over a wider area, making it incredibly resistant to collapsing.
Exactly. The clinical utility of ACM is undeniable.
But
But the limitation comes down to basic OR economics.
yeah, real life.
Nipple reconstruction procedures are notoriously poorly reimbursed by insurance carriers.
Dropping a highly expensive piece of ACM into a low reimbursement case completely obliterates the financial margin for the practice.
It drastically increases the overhead cost of the procedure. Costal cartilage often solves the anatomical problem while remaining far more cost-effective for the surgical center.
That makes sense. But regardless of the material used for scaffolding, the structural phase is only half the battle.
True.
I mean, you can build the most structurally sound projecting nipple in the world, but if it remains a skin-colored bump, the reconstruction falls completely flat visually.
Yeah, the human brain relies on specific visual cues to recognize three-dimensional anatomy. Without the contrast and shading of the areola, the structural work loses its impact.
So the final phase requires color and shadow. Tattooing is typically performed 6 to 8 weeks post-op, right? Once the tissues have completely settled, the edema is gone, incisions are fully healed.
Right. And the tattooing phase shifts entirely from surgical mechanics to pure artistry. The goal is to use light pigments and dark shading to create a robust 3D illusion on the surrounding skin.
It functions exactly like contouring makeup.
Exactly like that.
He used targeted shading to simulate depth and lighter pigments to simulate highlights. A skilled medical tattoo artist can add microshadows to simulate Montgomery glands, making a relatively flat patch of skin look like it has an inch of projection simply by manipulating the optical perception.
And this specific capability opens up a highly strategic clinical pathway. When dealing with patients who have heavily irradiated, highly tenuous skin,
Tissue that you know definitively cannot support a local flap.
right, and would almost certainly extrude a cartilage, graft skipping the surgical scaffolding entirely is often the smartest clinical call.
Just bypass the scalpel and rely entirely on the ink.
Exactly. Using advanced 3D tattooing as the sole, definitive option completely avoids the surgical morbidity associated with grafts and flaps in compromised beds. It's incredibly safe, and the visual illusion is highly convincing.
But the economic realities of the practice impact this phase as well.
Of course.
Medical tattooing is an incredibly specialized, time-intensive skill. However, because it's bundled into the global CPT code for the primary nipple reconstruction, insurance carriers do not reimburse separately for the time and artistry required to execute it properly in the office.
That bundled reimbursement model is highly frustrating, and it is driving a significant shift in practice management. Surgeons are increasingly delegating this specific work.
We're seeing widespread partnerships with outside cosmetic salons or practices bringing in specialized medical tattoo cosmetologists who operate entirely outside the traditional insurance model.
Charging cash for the aesthetic service.
Exactly.
Let's address one final practical scenario before wrapping up the clinical mechanics.
Okay, hit me.
You perform a beautiful local flap. It looks perfect on the operating table. A year later, the patient returns, and the flap has atrophied significantly. They need a secondary tweak to build a little more projection, but you really want to avoid cutting into the tissue again.
Oh, this is where the off-label use of injectable dermal fillers provides a massive advantage. It is a brilliant solution for minor volume depletion.
But the injection technique dictates the success here. If you simply insert a needle and inject hyaluronic acid into the base of the flap, the filler will follow the path of least resistance.
Right, it'll just disperse widely, radially into the surrounding tissue. You gain width, but you gain zero targeted vertical projection.
So what's the solution?
The physical barrier hack using a 3cc syringe. You take the plastic base of the syringe and cut a vertical slit directly into the side of the plastic wall. You place that hollow base firmly over the nipple.
And then you slide your needle through that customized slit.
Yep. As you raise the wheel in the skin, the rigid plastic base of the syringe acts as a physical retaining wall. It traps the filler strictly within the footprint of the nipple base.
It prevents any wide radial dispersion and forces the expanding tissue directly upward, maximizing your vertical projection.
It's so elegant. You typically inject a very small volume, roughly 0.3 to 0.5 cc's.
Now, because it is a hyaluronic acid filler, the body will naturally absorb it. You will have to repeat the injection every 3 to 6 months to maintain the result.
That's right. But it provides a fast, scalpel-free method in the clinic to maintain that visual anchor when minor atrophy occurs.
So let's look at the key takeaways from the real-world mechanics. First, abandon the tape measure during the marking phase.
Yeah, mathematical triangulation fails against the reality of tissue vectors. Utilize the uncover aesthetic method to find the true apex.
Second, if you are utilizing autologous tissue and raising local flaps, you must overcorrect your vertical projection by up to 75% on the table to combat the inevitable postoperative atrophy.
Definitely. Third, when you pivot to costal cartilage for prosthetic cases with thin skin, preserve the underlying capsule at all costs to maintain your vascular bed.
And always use a raube to soften the anterior edges of the graft to prevent pressure necrosis and extrusion.
Finally, deploy the 3cc syringe physical barrier trick when utilizing injectable fillers for secondary scalpel-free touch-ups. So the challenge for your next case is to trust your aesthetic eye over your surgical instruments during the marking phase.
Hand the patient the round adhesive bandage and let them dictate the initial positioning. Their aesthetic instinct often solves complex anatomical puzzles.
It really does. But the current state of nipple-areola reconstruction is just a constant battle against the body's natural tendency to flatten, absorb, and contract.
We harvest flaps fully expecting them to atrophy, We carve cartilage knowing the ever-present risk of extrusion.
We rely on tattoos, knowing statistically that 60% of those pigments will fade enough to require a secondary session down the line. Given the high rates of flap atrophy, the extrusion risks inherent with homografts, and the fading of 2D pigments, will the future of nipple reconstruction abandon surgical scaffolding entirely?
That's a fascinating question.
Imagine a protocol that bypasses the scalpel, the cartilage struts, and the dermal pedicles altogether. We may soon rely on advanced, permanent 3D bioprinted prosthetics that are custom-matched to the patient's exact anatomy and adhere permanently directly to the skin surface.
No local flaps, no extrusion risk.
Just a perfect, lasting keystone placed precisely where it belongs. Something to think about.